Good evening, everybody, and welcome to our webinar on female incontinence. My name is Jan, and I am a nurse specialist at Benenden, and I will be your host for this evening. Our expert presenter is consultant urogynecologist, Mr. Abhishek Gupta. This presentation will be followed by a question and answer session. If you'd like to ask a question during or after the presentation, please do so by the Q&A icon, which you'll find at the bottom of your screen. This can be done with or without giving your name. If you'd like to book your consultation, we'll provide you a phone number at the end of the session. And please note that this webinar is being recorded. I'll now hand you over to Mr. Gupta, and you'll hear from me again shortly.
Thank you, Jan. So as Jan said, my name is Abhishek Gupta. I'm a consultant urogynecologist. I got trained in Southeast London rotation. So my teaching hospital base was Guy's and St. Thomas's, and then I got trained in Kent, and then I developed a special interest in urogynecology, which is prolapse and incontinence patients, and I grew interest more because the problem of incontinence and prolapse does affect patients in a very different way. They affect patients' quality of life and their confidence, which is different than somebody who's got cancers and all that. So, but it's very rewarding when you can treat and improve somebody's quality of life. And that's how I got interested into it. So I completed my specialist training around this area. And then I've been a consultant for more than 10 years and has been practicing. And my private base is at Benenden Hospital. So that's me. We'll just talk about what, so that's me. Consultant gynecologist and urogynecologist specialist. Then we'll talk about incontinence in today's webinar, and I'll try to explain what incontinence actually means. What are the confounding factor which leads to incontinence? What can we do to make your quality of life better in terms of treatment, and also how we investigate this. Investigate it so that we can get to a point where we can start offering you the treatments. So that's kind of structure for this webinar. So we'll talk about what is incontinence, what different type of incontinence are, investigation and what examination we're looking at, how it can be managed without medication or surgery, and then if needed, how we do surgeries and do the medication and the treatment. So what is incontinence? So that's obviously an involuntary leak of urine, which is involuntary and it's a leak. And that's what is urinary incontinence. So it's not a voluntary passing urine, it's involuntary. Now, how common it is? So you can see on my slide, it's almost 30, anything reported between 30 to 40%. So if you imagine every third to every fourth patient, woman, not a patient, woman, will experience some form of incontinence in their lifetime. There are predominantly two kinds of it. One is urgency of incontinence, and others is stress incontinence. And most of the incontinence in a patient is usually a mixed picture. So what is urge incontinence? Urge incontinence is when you get urgency to go for waterworks, you can't hold. It's typically presented that you need to rush to empty your bladder. So you get the urge and you need to go straight away. That's typically what urge incontinence is. And you might have to go more often. You may have to get up in the night because your bladder can't hold after a certain while. So if you imagine your bladder like a balloon which stretches when water is filled in or urine is filled in, your bladder can hold, in normal average woman will, anything between 350 mL to 500 mL is a normal bladder capacity. The patients who have got urgency of waterworks, either urgency and some people who have leak, when bladder is expanding, the bladder starts doing this, which is contraction of the bladder. It's completely involuntary. The bladder muscles are not under your control. So when this happens, you see a balloon trying to squeeze water out. It gives you a sense that you need to rush for waterworks. And if you don't reach there, you start leaking. That's called urge incontinence. And some of the factors, which is neurologically, you will see how it typically affects or can present is some people feel they need to go for passing urine. They're in the car, they get out of the car, rush to toilet. As soon as they put a key in the door, they start leaking. That's typically called key and lock effect. You are in the kitchen, open the tap, sink, you hear the water trickling, and you start getting, I need to go for waterworks. That's the urgency of waterworks. Then second is stress incontinence. What stress is? So it's not mental stat, it's physical stress. So typically the patients will present with leaking, coughing, sneezing. When they go for exercise, they lose control and they may have to wear a pad for going there. So what happens with stress incontinence is if you imagine, again, the bladder being a balloon, which is full of water, the tube which drains water out is called urethra. So when inside your tummy, when you cough, sneeze, jump, or exercise, the tummy pressure increases. What tummy pressure is doing is trying to squeeze the bladder to leak water out. Now, the same pressure is coming on a hollow tube, which is called urethra, which drains water out, which is connected to the bladder. The pressure comes from the top, and if you have enough of pressure on the bottom, say when you never had children or they never had problem, this hollow tube which drains water out closes. So pressure from the top, pressure from the bottom, it closes. If you have a weakness in that area, which is the tube just below the tube where the bladder is, which connects to bladder, if you've got weakness in this area, this tube doesn't close, it kinks when the pressure comes out. So there's enough of space for urine to start leaking. So that's what stress incontinence is. Majority of patients will present to us with a mixed kind of picture. So some people, because their body cannot differentiate. They generally may have a mixed incontinence, that they have got overactive bladder and the stress incontinence as well. But majority of them will present to us with mixed picture because their body can't differentiate. For example, if you got stress incontinence, you will train your mind to make sure that you keep emptying the bladder. What that means is you don't want to go anywhere with a full bladder because you don't want to leak in public. So you will habituate yourself to keep going for waterworks more often to make sure that you don't embarrass yourself, or you don't feel you feel more confident going out. And that becomes a habit. And then when you present, you feel that you're going for waterworks often. You're always looking to go for toilet when you're in a shopping mall or somewhere else. And that's where you're getting the mixed picture. But however, initially, for stress incontinence, your body is trying to overcompensate so that you don't have embarrassing moments. And most important thing, it's a problem. It's an issue, and it's an issue when it becomes an issue for you. And everybody's symptoms are different. Everybody's quality of life is different. So gone are the days when we say this problem used to be an older generation problem. It happens to young people as well. And the most important thing is to come out and talk about this problem if you feel this is affecting your quality of life. You've got 2 little children and you're say 28, 30, 29 years old, and you cannot do trampoline with them because you have stress incontinence. This is affecting quality of life and you should come and talk about it. If it's not, and this, don't be embarrassed. There are a lot of people, we run these clinics, both in NHS and Benenden, dedicated for this problem. So this is such a common problem. And as I said, every 3rd or 4th woman will have this kind of issues. And then we need to know how to effectively manage this. So what are the typical causes of incontinence? So first, let's talk about the urge, which is the overactivity I'm talking about. So if the bladder is doing this, you'll feel urge to go for waterworks. So what happens, as I was describing you, urgency is caused by the detrusor muscle, which is the muscle of the bladder. So when they become like this, then this becomes an overactive muscle, and that's called detrusor overactivity. So if it's doing this, you'll find urgency, frequency of waterworks, and if it goes like this, then you'll start leaking. Now, a lot of risk factors include if you're taking a lot of alcohol, tea, coffee, or fizzy drinks. So basically caffeine irritates the bladder, and it makes it triggers your receptors. It makes the womb it produces a lot of urine, and plus it helps, it also activates the muscle receptors to go into this kind of motions. So if you're drinking quite a bit of tea, alcohol, fizzy drinks, then caffeine, then you might have to reduce them. And for tea and coffee, you may have to make them decaffeinated. And similarly for fizzy drinks like Coke, and this has to be reduced. If people smoke, it does trigger the nicotinic receptor, and it's very difficult to get on top of bladder problems if you are a heavy smoker. And sometimes you've got urinary tract infections, which happens again and again. And if you have urinary tract infection again and again, it does scar the bladder and makes them very sensitive. And some neurological conditions, like especially like MS, which is affects the nerves, and that can cause your bladder to go into spasms and overactivity. So these are some common issues and risk factors which can cause overactivity of the bladder. What causes stress incontinence, which is a leak, involuntary leak when you're doing some form of exercises or coughing, sneezing? It's, as I described, it's the weakness in the neck of the bladder area, which is either inside the bladder, which is called sphincter, or just at the level of the vagina where the tube, which is draining water, comes out. The risk factors include number of vaginal deliveries, especially if the instrumental delivery like forceps, there are quite a bit of trauma to pelvic floor. Then obesity, because it weakens your pelvic floor, and unfortunately, as we all get older, our tissues are not that strong, and there is a lot of laxity. Then other traumatic factor, which unfortunately a woman's body goes through, is menopause. And menopause causes lack of estrogen, and lack of hormones means the tissues are not that supple and they're not that strong. And I think the menopause, an effect on incontinence and the vaginal health, is highly underreported. And this causes a lot of issues, incontinence as well as discomfort. If you have smoking, you will always have poor tissues. And even if you want to have an operations in future, then the success rate reduces if you constantly smoke. And again, if you've got a bad chest and chronically cough, then it will weaken the pelvic floor. Other things also, which is not there in this slide, but if you have a tendency towards constipation, please treat them. Because constipation can be a worst enemy. And if you are chronically straining, you're going to keep traumatizing your pelvic floor. And some neurological disorders where the bladder, if you got a little fistula, which is a tract between bladder and the vagina, if there is a through and through tract, or other neurological disorder which causes problem with sphincters, which is what controls in the continence, then neurological issues can cause both overactive bladder as well as stress incontinence. So how do we investigate and diagnose it? So when we get referred the patient, we ask Jan and her team to review the patients. They assess you, and they also, a lot of patients may not need to see a consultant, because sometimes the lifestyle adjustment and conservative treatment is all what they need. And Jan will talk about it in a minute. So what would like to see, if you got predominantly bladder issues, to see a bladder diary for 3 days. What we want to see in a bladder diary is how much you drink, what kind of drinks you drink, and how often you go for urination, how much volumes you pass urine, and how many times you leak. So for example, if you got overactive bladder, that means your bladder is never going to fill up properly, because they're always doing this. You typically, if you fill this bladder diary, you will have going to waterworks more often. You may get up in the night few times, and the amount which comes out is small amounts, anything between 50 mLs to 150, 200 mLs, because your bladder can't hold, and you will have a sense of urgency. Then we can also see if you are consuming a lot of drinks which are irritant to the bladder, And similarly, if you've got stress incontinence, predominantly stress incontinence, you can typically hold bladder well. You don't have to get up in the night that much. You wake up in the morning, you've got bladder of 400, 500 mLs, which is normal for most of the people. And then you can hold it longer. You don't go for water work that often. And when you leak, it's usually with some kind of activity. So bladder diary can be very helpful for us to triage what kind of incontinence you have, and if there are anything which we can do to help you out looking at your behavior, your day-to-day consumption and your symptoms. It also helps. So some people have, for example, nocturia. What that defines is getting up in the night to go for waterworks, which can be physiological. When we get older, it is known that we get up a couple of times more in the night. But if you're drinking a cup of tea at 11 o'clock in the night before you go to bed, then more than likely you will be getting up in the night. So if you have the bladder diary, we can pick that up and discuss with you how to do what is called fluid management, which may be what you need, because remember, all this is to improve your quality of life. Obviously, we ask the questions. Then there is a scoring chart, which is designed by, which is accredited by British Society of Urogynecologists. It gives us a number just to see how this symptoms of ear correlate to how much is affecting your quality of life. Then most of the time, if you come with urinary incontinence, we do perform internal examination, to assess the leaking, see what your pelvic floor is doing, and if you've got any signs of significant prolapse. And we also like to examine to pick up if you've got any fibroid, cysts in the ovaries, or anything which is pressing on your bladder. And after this, if symptoms are not, your symptoms after conservative treatment are not help, then we perform a test called urodynamic assessment, which tells us exactly how your bladder is behaving. So in the urodynamics, what we do is to put a catheter in the bladder, and then a small catheter goes in your back passage just to read the pressure. Then fill up the bladder with water, see the changes of the pressure on the bladder. So that tells us differentiation between overactive bladder and stress incontinence. When bladder is relatively full, we ask you to cough. And if we see the leak and the bladder is not, if bladder pressure doesn't go up, that means we're seeing stress incontinence. Then we ask you to empty your bladder in a pot in the urodynamic room, which tells us how fast you wee. And it also tells us if there is any obstruction which makes you not being able to empty the bladder well, which can happen if you've got a major prolapse. So urodynamics is that test. It takes roughly, what I'm describing, it seems quite intrusive, but actually our continence nurses make them look very easy, and it's not painful. It takes roughly 45 minutes to do the test, and mostly at the end of the test, we get a clear picture of what next steps should be. Jen, I'll let you take through the conservative management.
Lovely, thank you, Abby. I think Abby's probably covered most of the things already, but obviously the conservative management, we're going to test your urine. We want to make sure that you haven't got a urine infection. And again, we can get you to empty your bladder on something called a flow commode to measure your flow rate. And also quite importantly, just a simple scan of your bladder to then just check you are emptying your bladder properly. There's always the risk that actually you've got the overactivity because the bladder's not emptying out properly. We'll spend a lot of time going through the bladder diary. We want to give you all the advice about your drinking. Are you drinking everything all in one go? Is that why you're emptying your bladder every hour? It's spreading your drinks out through the day, advice about caffeine, and also a bit of advice around things, dietary things. If you have a lot of fruit juices, a lot of acidic things, that's potentially going to make that urine fairly acidic. And again, that's going to give you symptoms of overactivity. The bladder retraining, we'll look at your bladder diary and we'll start from there, and we'll say, actually, when you get that urge to go, can you start by just holding on for 5 minutes every time? Can we then increase that to 10, 15 minutes to try and get your bladder to hold a better volume of urine? The pelvic floor exercises, they're key, and that doesn't matter if you've got overactivity symptoms, if you've got stress incontinence symptoms. Pelvic floor exercises for at least sort of 3 months to get hold, if you like, of your symptoms and get some improvement. Will help to support you along with things like weight loss. Obviously, as Mr. Gupta said, if you're overweight, there's more pressure then onto that pelvic floor. And again, around stopping smoking, smoking being a real irritant to your bladder, particularly for overactivity. Next slide, Abby, thank you. So looking at conservative management, as I say, when we've done all of the things on the previous slide, what we'll do is we'll either give you a telephone call at sort of a couple of months, we'll see you back in the clinic face to face, whatever works best for you. And if we've tried all of those conservative things for your overactivity and we're not really thinking things are getting any better, then there's the option of looking at something of medications. So there's 2 types of medications you can have for overactive bladder. The first is what are called anticholinergic. So they work on that bladder muscle to calm that bladder muscle down, so you don't get that urge as quickly, and it just gives you that time between getting that urge and getting to the toilet. There's a whole host of those, oxybutynin, solifenacin. They do have side effects. They can give you a very dry mouth, and that can be quite difficult to cope with, particularly because we're trying to manage your bladder. But sometimes just sticking with it, and the symptoms will start to improve. And medication can either be something that we ask your GP to prescribe, or if you've seen the consultants, they may prescribe that for you here. A different type of medication is something called mirabegron. And again, that still works on the bladder, but it works on the inside of the bladder. It's all about relaxing it down, so it's not picking up those signals as quickly. We do offer here something called tibial nerve stimulation. It's only available on a private basis, and that basically just works on having a little acupuncture needle in your ankle, and the tibial nerve runs sort of from your ankle all the way up to your spine, to the base of the spine, and it's involved in maintaining bladder function. It's a 12-week course, and again, it's not used that often, but it is always another option. If you're looking at the stress incontinence, if you're following the national guidelines, structured pelvic floor exercises for at least 3 months. And it's going to take 3 months to just wake that muscle up, to get it used to the fact it's supposed to be exercising. If you go to the gym, you're not going to be able to lift the big weights on week 1. So it's just building that up. And then we'll reassess you. We're your point of contact. We're here to help you all the way through. Thank you, Abby.
Thank you, Jan. So thanks for covering it comprehensively. So just to add on with the medication for active bladder, so anticholinergic medication, which slightly has got more side effects. Basically, what they do is they prevent, so oxybutynin, solifenacin, or anticholinergic, they prevent the contraction of the muscles. And mirabegron relaxes the bladder. So there's certainly 2 different actions. One is preventing the contraction, one is relaxing the bladder. That's how they work differently. And with stress incontinence, as Jan was saying about structured pelvic floor exercises, and the other thing, if you could look into nice guidance, then optimizing your weight, which is important both for success of the operation as well as for if you ever go for an operation, the complication rates and recovery periods are better if you optimize your weight. So what are the surgical options now? So if hopefully the conservative options will help your quality of life, but some people, the forms are quite severe, and conservative options work to a certain extent to improve the quality of life, but it's then if it's not helpful and it's still affecting quality of life, then we'll have to go down the route of surgical options. So for overactive bladder, which is urgency and urgent continence, and the bladder is doing this always, if the medication hasn't helped or you get side effects of the medication, then what we often offer is a bladder Botox procedure. So it's a procedure which is done in outpatient here. We've got ambulatory care unit where we do the procedure. It's done with a little camera which goes into bladder, and then we give the injection of Botox on your walls of the bladder. it's fairly very effective procedure. And the patient who really has overactive bladder, where your bladder is doing this is really affecting quality of life, bladder Botox helps really well. It's not painful. It's very well tolerated in outpatient under local anesthetic gel. There are two things to know about the Botox injection. One is at some point it will pass off your body, so you may need it repeating. It's very difficult to say whether you need repeat in 6 months or 2 years, but when your symptoms come back, you may have to repeat it up. And sometimes 1 in 12 women approximately, the Botox relaxes the bladder quite a bit, and you're not able to empty the bladder well. And hence, before you go to Botox, Jan and her team always teach you and empower you how to catheterize yourself, just in case if need arises in future. Just in case it needs arises in future. And this is able to do a catheterization yourself sounds more daunting than it is. It's fairly easy process, and it is not difficult in majority of the cases. And once taught, it really empowers you with this procedure. So don't get scared about if you ever need to go for a Botox and have to catheterize for some time. Then stress incontinence. So stress incontinence is when you leak, when you cough, sneeze, or lift weight and all that. Now, there is a nice decision aid on stress incontinence surgery, and you can Google exact those words, nice decision aid for stress incontinence surgery, and you'll get a whole decision aid which is written for a patient. So it's written in a language you understand very easily, and it's a decision aid which will help you to then choose what surgery you need to have, and it's done by NICE, which is National Institute of Clinical Excellence. So this is a guidance we all follow, and this is quite a good decision aid. When you come and we go through surgical options with you, we always follow a nice decision aid, and we actually give you a copy to take it home to read it further. So what are the options for stress incontinence surgeries? So there are basically 4 options, and I'll go through the two most invasive options, and then we'll go to less invasive options. So the most invasive options are called A, colposuspension, suspension, and B, autologous rectus fascial sling. So what colposuspension suspension does, colposuspension suspension was a gold standard operation before the meshes came in. And what we do with colposuspension suspension operation is either through a Bickney line incision or a keyhole, we go from the tummy very deep into the pelvis, and from vagina, we lift the vagina up, put the stitches just next to your bladder neck, and stitch it with a bone. There's no mesh involved, stitch it with a bone, and it lifts the front of the bladder like this. So it again gives a support just at the neck of the bladder levels by lifting the pelvic floor, just lifting the vaginal wall in the front up like this. So it gives you support there. So autologous rectus fascial sling is again a Bickney cut incision. We take out your own tissue, which is called rectus sheath. Then we go through the vagina, and just at the neck of the bladder level, we put the sheath there, bring it up to the tummy, and suture it up. So we make a sheath as a hammock just below the neck of the bladder, which is your own tissue. And again, there's no mesh involved. So that's 2 surgical options where you usually are in hospital for 24 hours to 48 hours. And the complete recovery after this operation takes around 6 to 8 weeks. The success rate for both two operations are roughly around 80-85%. That is, the NICE quotes their success rate of around 70 to 80%, but the success rate are around 80 to 85%. What we are saying, and what I mean by success is how it improves your quality of life. So that's what success rate is improvement in your quality of life. So 80 to 85% success rate. On the flip side, it's both are fairly major operation, and you will need 6 to 8 weeks to recover. We always send home patient with a catheter for a week because we need things to settle down, the swelling around the operation site to settle down before you can start weeing. All the patients come back to Jan and her team in a week's time, or a week to 10 days time for removal of the catheter, 90% of patients will start passing urine very well by that time. 1 in 10 women, we may have, Jan and her team might have to teach how to catheterize yourself. And again, I said, don't get worried about catheters till the things settle down. And that all the patients do settle down with time. It's just a matter of time how long it takes for healing to process, to settle up, and things to settle down. This is, I would not go into too much detail with that mesh operation, which is TVT, because nationally it was a day case operation, and I still feel that in right circumstances, in the right hand, and for the right patient, this is it's a good surgery, and it's still nicely commensurate. But meshes are on a national pause since 2018, so it's more than 4 years. So we haven't done for more than 4 years, so we're not doing them anymore. So I think they're still on your nice guidance, but nationally it's not been offered anywhere in the country at the moment. Then the last option is bulking agent, which is called Bulkamid. It's a hydrophilic gel, which is 97% made of water, and it's a gel. So how the gel works is it can be done in a local anesthetic procedure. So advantage is a local anesthetic procedure. There's no downtime. There's no long recovery period. It can be an office procedure, get it done, go home, start working on day-to-day activity. So the way it's done is we give, it's again done in our ambulatory care unit, where we do our cystoscopy and Botox injection. We give local anesthetic injection just next to urethra, which is a tube which drains water out. And then with a camera, we look inside the bladder, and just at the neck of the bladder level from inside, we give 4 sites of this gel. It bulks that area up so that it gives you support to the urethra for urine not to leak. The advantage is it's a least invasive procedure. It's done in a local anesthetic. It's a permanent gel. The disadvantage is the least successful operation procedure as well. Success rate is roughly around 55 to 60%, and it may need repeating. But if somebody, excuse me, if somebody who is not completed a family, want to have more children, we try not to do major surgery. We try to offer you Bulkamid if it's affecting quality of life. Some people who are not ready to have major procedure for their own, for one reason or another, they want to avoid surgery, they can offer Bulkamid. For the patients who are unfit for surgery, some patients have got comorbid health condition, which doesn't make them fit to have major surgeries. They can still have Bulkamids for the procedures, and that's helpful. And it gives you a decent quality of life. So it has a place, and we do it quite routinely. And as I said, the success rate around 55 to 60% for the quality of life. So this is where NICE will tell you success rate, and I like the decision rate because it's written as patient in mind, so how patient perceives it. So this is corpus suspension in 5 years time. NICE quotes a success rate of 70%. Usually we quote a success rate of 80%, 85%, because that's how usually patients we get who are happier, or the quality of life is better. And similarly, the rectus fascial sling, NICE says is slightly better with this terms of success with comparison to corpus suspension. But again, it's ballpoint figure about 75, 80%. So roughly around 8 out of 10 women are happy with both of the surgeries and their outcomes. And we won't go into mesh too much because meshes are still on a national hold. And before I leave on this, we record all our incontinence surgery on a national database, which is called British Society of Urogynec database. So it's not mandatory, but any doctor or consultant urogynecologist who do incontinence or prolapse surgery, it's a national recommendation that we should be recording our cases on a database for purely audit purposes. So at a click of the button, I should be able to tell how many patients I do in a year, what my success rates are, and what my complication rates are. And that's how I can give you the data about what success rate looks like and what complication looks like and how many patients do go into retention and what our outcomes are. So that's a national database, which we use both in NHS and in Benenden. And and that's how we constantly audit our results. Jan, over to you.
Thank you. So before we go to question and answers, I just wanted to briefly talk to you about the Women's Health Hub. This has been set up recently, and it will cover all of the health things, regardless of what age you are. So I'd really advise you to go on there and have a look. They'll give you information about managing periods, heavy periods, about your sexual health, about mental health, menopause, perimenopause, postmenopause, keeping active, health at work. So as I say, go onto the website, have a look, and you're going to find a lot of useful, helpful information on there. So if we move to question and answers, Mr. Gupta, I've got a letter here. Hold on, bear with me. It's now 15 years since I had my hysterectomy, and I feel my bladder is becoming progressively weaker. I'm 64 and probably visiting the toilet 2 to 3 times in the early hours of the morning. Is this normal?
So 64, I think age is just a number. But I think if you're getting up 2-3 times early hours in the morning and you're not drinking till late in the night. So if you're drinking till late in the night, and especially if you have a caffeinated drink, then just cut down your drinking at least 2 hours before you go to bed. And if this is a problem for you, then we can have a look. But if it's not a problem for you, it's nothing to worry about. Continue doing pelvic floor exercises and just change what you drink and what time you go to bed. So this is conservative options and management, and you can manage it. So it's not a problem till it becomes a problem for you.
Thank you. Next question is, can stress incontinence be cured by diet and exercise? And if so, how long does this take?
So stress incontinence can be helped by, if in the diet, is if you have, as we said, if you're obese, then diet will help. When you reduce weight, it can help with stress incontinence. And pelvic floor exercises, if it helps in 3 to 6 months time. So if you reduce or I shouldn't say reduce, but if you optimize your weight and do pelvic floor exercises, and in 6 months time, it should help with stress incontinence if it has to. So if it doesn't help by that time, then you will need specialists. You should seek specialist help if it's affecting quality of life. So it can, the diet, there's no particular dietary factor which will help stress incontinence, but it's just optimizing weight which helps.
Thank you very much. I think I can answer the next question, which is how much tea is too much, or in fact, how much quality of liquid in a day? I drink on average 4 cups of tea a day, no coffee, and I drink also at least 1.5 litres of water. So what I would say to that, as I say, that's where we're looking at your bladder diary. We would generally say 2 caffeinated drinks of tea in a day is going to be fine. Maybe have those in the morning, and I'd be tempted to say get yourself some decaffeinated and have other fluids during the day. Keep that drinking round about 1.5 to 2 litres in total. If you're exercising, you may need an extra, 500 mils of water. So you may, on those occasions, need to have up to 2.5, but keep your drinking around 2 litres. Next question, Mr. Gupta. I'm 56 and postmenopausal. I've just started to notice a bit of leakage. At what point should I seek help for this incontinence?
So seeking help for incontinence is always when you think it's starting affecting your quality of life. So its quality of life can be very different. So your quality of life may be that you're just going out for a walk and that doesn't affect you. You're using a small panty liner, it's not affecting you. Then you really don't need to go down the route of any surgical option. But it's worth seeing someone like Jan or continence care specialist to go through exercises and pelvic floor, but there's no point having any surgical or any invasive investigation like urodynamics at that point. But if it's starting to affect your quality of life, if you're 56, you may like to go for a long walk, you might like to play tennis, or you might like for running, or you have very you, some of my, I mean, I recently saw a patient who goes for a lot of dancing, and she was in her late 50s. And if that's starting affecting her, what she wants to do day to day, then I think that's the call when you start needing to take some specialist help. So it's when this starts affecting quality of life. But if the incontinence started, then it's worth at least seeing either a local physiotherapist or seeing someone who's got a specialist in continence care to go through exercises.
Thank you very much. Next question. I often need to go several times in the morning, but for the rest of the day, I can hold bladder for even longer, even though I drink regularly. Is this a normal part of aging, or do I need to seek any help?
I think it's all usually, I don't know whether when you say it's normal part of aging, what your age is, but usually we wake up in the morning and we have a cup of tea, most of us, and a cup of coffee, and we go for water works a bit often in the morning, which is normal. If it's not affecting your problem in all day long and in the night, I wouldn't worry too much. But just also notice if you're on your medication, what medication you are on. If you're on a water tablet, you take in the night, you may go for water works a bit often in the night or the morning. And if you have a lot of swelling in your leg, sometimes there's a lot of fluid which gets accumulated on your leg, which is called lymphedema. When you sleep in the night, it comes back into the body, and then it makes you get up in the night or go in the morning bit often. And that's not related to bladder. It's just you're producing more urine. Otherwise, it's not a problem.
Thank you. So I can answer the next question. I'm constantly worried that I have an accident when I'm out and about. So I go to the toilet as often as I can. Is this a bad habit to get into? And basically the answer to that is yes. The more often you keep going to the toilet, your bladder will start to think, actually, I'm only supposed to hold half a cupful of urine, whereas we want that bladder to be able to hold 2 cupfuls of urine, a good 300, 400 mils. So the more often you go, and it sounds like a sensible thing to do to manage the leaking, but you're almost storing up more problems. So my advice would be, if you're drinking 1.5 to 2 liters, you should be able to empty your bladder somewhere between 2 and 3 hourly. So if you're going any more than 2 hourly, try and work on the bladder retraining. Try and just hold on, use your pelvic floor muscle, or if not, look at getting yourself a referral here to the continence care team so that we can help you out with that. Mr. Gupta, after a multiple myomectomy to remove fibroids, my bladder was impacted and urge incontinence has definitely increased. I'm looking forward to hearing if anything can help.
Yeah, I mean, if you're, as we said, if the conservative options haven't worked after the surgery, it can be sometimes scarring helps. Scarring can cause more of issues as well. Then we can go down the route of having a urodynamics to exactly see how your bladder is behaving, which is the test I was talking about during my presentation. And the urodynamics does confirm that you cannot hold the bladder that well, or your bladder can't hold the urine that much. Then we can either start your medication, which will help, or if it's quite a bad overactive bladder, then we can always go down the route of Botox and see whether it helps you.
Thank you. I've noticed an increase in stress incontinence since having long COVID. Could this be the way the nervous system has been affected?
I haven't come across COVID affecting stress incontinence, but obviously we don't know everything about COVID yet. But I have not come across that virus will cause you more stress incontinence. But if your COVID has affected your chest and you had developed a lot of coughing, that is more likely affected your pelvic floor and increase your stress incontinence than virus itself. So if you've got long COVID and have a bad chest for some time, that probably has affected your stress incontinence more than the virus itself.
Thank you. Does being overweight play a big factor in needing to empty your bladder more frequently?
I mean, it gives a pressure to the bladder or pelvic floor. Not so much with overactivity, but stress incontinence, yes, with weight. But the important thing to understand, if you've got significantly overweight or you're in obese category, is the treatment for bladder doesn't have that kind of success rate. And especially if you have any operation, the success rate are reduced and complications are increased. And when we go down the route of surgical output, surgery for any form of surgery for bladder issues, doing the first shot of surgery is always the best shot in times of success. Repeating the surgeries are not as successful. So if you ever have to go down the route of surgery, we should optimize everything first before we consider doing it. But obesity doesn't usually cause overactive bladder. But if you're obese and you have overweight, then usually it's diet related. So you may like to look into your diet about if you have very high sugar intake, or you have high intake of fizzy drinks with sugar, which is affecting your bladder. But obesity per se should not cause you overactivity of bladder.
Lovely. Thank you. Can we have next slide, please, Mr. Gupta? One more slide. Thank you very much. So thank you for attending our webinar. I'm sorry if we haven't answered all your questions, but if you provided your name, we'll do so after the event. If you'd like to book your consultation, please contact the number on your screen between 8 a.m. and 6 p.m. Monday to Friday. And we are offering an attendee discount for this session with the terms on the screen. You will receive a short survey, and I'd be grateful if you could please spare a few moments to let us have your feedback. And we hope you have enjoyed the webinar. The next webinar is on Wednesday, the 2nd of November, and that's on cosmetic surgery. So on behalf of Mr. Gupta, myself, and all of the team at Benenden, I'd like to say thank you for joining us today, and we hope to hear from you very soon. Thank you very much. Goodbye.